Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at University of Pittsburgh, and today we will be discussing adult Hodgkin lymphoma. Keep in mind that for Hodgkin lymphoma, there is a difference between adult and pediatric treatment paradigms. And in this talk and this series, we're really going to be focusing on adult treatment paradigms. The term lymphoma actually encompasses a very heterogeneous entity of cancers, different types of cancer arising from our lymph nodes, essentially. When we broadly think about lymphoma, we think about Hodgkin lymphoma versus non-Hodgkin lymphoma. And classically, what has always characterized Hodgkin lymphoma is the presence of Reed-Sternberg cells. These are unique cells that have this binucleated appearance, and they are CD15 and CD30 positive, and they have that classic owl's eye appearance. That is sort of the classic feature of Hodgkin lymphoma, and we see it in classical Hodgkin lymphoma. Non-Hodgkin lymphoma is a completely different entity, and there are aggressive and indolent subtypes of non-Hodgkin lymphoma. There is something called non-classic Hodgkin lymphoma, also known as nodular lymphocyte predominant Hodgkin lymphoma, which does not have Reed-Sternberg cells. It actually has something called popcorn cells, which are multilobulated and historically thought of as kind of a variant of Reed-Sternberg cells. That historically was classified as a non-classic Hodgkin lymphoma, but we always knew that it behaved more similarly to an early stage, low-grade, kind of an indolent non-Hodgkin lymphoma, and it was managed very differently than Hodgkin lymphoma. It was treated like a low-grade B-cell lymphoma, and in fact, it is now actually being reclassified as a nodular lymphocyte predominant B-cell lymphoma. So I only include it here because historically it was classified as a non-classic Hodgkin lymphoma. But when you think about lymphoma, what you should realize is that there are many different types of lymphoma. There are very kind of complicated ways of classifying them. But very basically, when we think of lymphoma, it's either Hodgkin lymphoma or non-Hodgkin lymphoma. And the classic feature of Hodgkin lymphoma is the presence of these Reed-Sternberg cells. So in terms of epidemiology, Hodgkin lymphoma is actually relatively uncommon, accounting for just around 10% of lymphomas in the United States. It tends to have a bimodal age distribution affecting adults in their 20s, and then it has a second peak around the age of 65. It does have a slight male predominance with a ratio of around 1.2 to 1. And overall, it's important to realize that Hodgkin lymphoma has a pretty excellent prognosis. It's highly responsive to therapy, and the 5-year overall survival rates are on the order of 85 to 90%, if not higher. And so it's important to realize that the prognosis is very excellent because these patients have an expected long-term survival that's very good. And so when we think about treating them, it's really important to consider the long-term toxicity of all of our treatments because we do expect these patients to live a long time. And so we really want to be careful with our treatments and spare them the long-term toxicities whenever we can. My hope in this overview talk of Hodgkin lymphoma is to review the presentation and workup of Hodgkin's disease, talk about staging and risk stratification, and focus on how we risk stratify early stage disease into favorable versus unfavorable, and then how we think about advanced stage disease in Hodgkin lymphoma. And then finally, we will end by talking about the treatment paradigms, so discussing some of the important aspects of chemotherapy and radiotherapy for this disease. In the next talk, then, we will get into the evidence and some of the important trials that kind of define these paradigms. So let's start with some basic background. Most commonly, Hodgkin lymphoma presents with painless lymphadenopathy. And when the disease spreads, it typically spreads to contiguous lymph nodes around 90% of the time. So patients can actually present with a pretty large lymph node conglomerate. If there is organ involvement, it can either be via direct extension or via hematogenous spread, and the spleen is the most common site of extranodal disease, so you want to assess for splenomegaly as well. When we're evaluating these patients, we always want to ask if they have presence of something called B symptoms. B symptoms are present in around 1/3 of patients, and presence of B symptoms is a negative prognostic factor, and it actually goes into our staging and risk stratification. So what are B symptoms? B symptoms are, there's three things. So fever greater than 38 degrees Celsius or 100.4 degrees Fahrenheit, weight loss of greater than 10% in 6 months, and drenching night sweats. The type of night sweats that make patients have to, change their shirt at night or something like that. Really drenching night sweats. So fever greater than 38 Celsius, weight loss of over 10% in the last 6 months, unintentional weight loss, and then drenching night sweats. If any of these are present, that qualifies as having B symptoms, and remember that that is a negative prognostic factor. Other symptoms that patients might complain of, which are not classified as B symptoms, include pruritus, fatigue, or sometimes patients will have alcohol-induced pain. Risk factors to keep in mind include HIV infection, EBV infection, any kind of immunocompromised status, and of course, family history. So remember that workup always starts with a full history and physical exam. Always inquire about history of those B symptoms. Pay attention to lymph node regions on exam, and perform a chest and abdominal exam, especially examining for splenomegaly and hepatomegaly. Especially in our younger patients, folks that are maybe in that 20 to 29 age group where we have that first peak, you definitely want to discuss fertility preservation, or really anyone that would be an appropriate candidate for fertility preservation. Labs, you can think about getting a CBC with a differential, CMP, so basic metabolic panel, but also checking LFTs into albumin on that CMP. You can check for LDH and ESR. Get a pregnancy test in our younger patients that may be pregnant, and also test for HIV, HBV, and HCV. Imaging, PET-CT is really the gold standard, and we can also think about other tests such as an echocardiogram or a Muga scan if we're considering doxorubicin for chemotherapy, because remember that affects our cardiac function, and also PFTs and DLCO if we're thinking about chemo, including bleomycin. So kind of thinking ahead of what the treatment is going to be and what those drugs are going to be. Additionally, if patients are going to need splenic radiation, you can consider prophylactically vaccinating them with encapsulated organisms. So our pneumococcal, Haemophilus influenza, and meningococcal vaccinations, the encapsulated organs that the spleen protects us from. Once you have kind of that basic imaging workup, it's also really important to get a biopsy. And excisional biopsy is the best biopsy, and it's really needed to see that the full lymph node architecture. Also remember that the Reed-Sternberg cells that are kind of pathognomonic for Hodgkin disease are very uncommon, compromising only 1% to 2% of our tissue sample. So we want to get an excisional biopsy whenever possible. Sometimes you might be presented with something like a large mediastinal mass or something that's not amenable to an upfront excisional biopsy. And in that case, the correct answer is to get a core biopsy. A core biopsy can be considered adequate if excisional biopsy is not possible, but remember that an FNA is absolutely inadequate. If the core biopsy is non-diagnostic, then you need to repeat the core biopsy, but getting an FNA is definitely not the answer. Typically, we do not pursue bone marrow biopsy unless patients have unexplained cytopenias or there is concern for bone marrow involvement based on the PET-CT scan. There's less than 5% likelihood of bone marrow involvement. So typically for Hodgkin disease, we're not routinely pursuing bone marrow biopsy. One thing to keep in mind when you are evaluating the PET scans for these patients is kind of noting how many different lymph node regions are involved. The reason it's important to identify how many different lymph node regions are involved is because that factors in when we think about the patient's stage as well as their risk stratification. And it's especially important for risk stratification for early stage Hodgkin lymphoma. I think it's kind of confusing because different study groups have different systems for the anatomical grouping of lymph node regions. And so Ann Arbor's system, for example, all of the different supradiaphragmatic and infradiaphragmatic nodal regions are listed here in this table from NCCN. The biggest difference among the groups is that the EORTC and the German Hodgkin study group kind of group the supradiaphragmatic nodal regions a little bit differently. So in Ann Arbor, cervical, infraclav, and axillary lymph nodes on each side are all separate, right? You have your cervical, then you have your infraclav, and then you have your axillary. And Ann Arbor keeps them all separate for the left as well as for the right. EORTC groups the infraclav and subpectoral nodes along with the axillary nodes on each side. So kind of think of how the lymph nodes that are involved in breast cancer, like those infraclavicular nodes, think how in breast cancer we all kind of lump them all together. EORTC does the same thing and lumps together the infraclav and the axillary nodes. The German Hodgkin study group lumps the infraclav nodes with the cervical and supraclavicular nodes. So the German Hodgkin's study group is different than EORTC in how they group the infraclav. Remember, Ann Arbor keeps them all separate. EORTC groups the infraclav with the axillary, and German Hodgkin groups the infraclav with the cervical and the supraclav. The other big difference is that Ann Arbor separates out the mediastinal versus the right hilar versus the left hilar nodes. EORTC and German both group the mediastinum and both of the hyla together. So that is just considered one nodal region for purposes of EORTC and German Hodgkin's risk stratification. And then in the infradiaphragmatic region, remember that the EORTC and Ann Arbor both group the para-aortic nodes with the celiac and splenic hilum, but the German groups the para-aortic nodes with the mesenteric nodes. And so this is something that, you will ultimately end up looking up probably when you're taking care of these patients if you can't remember these different lymph node regions. But for the purposes of the boards, it's probably good to kind of memorize one system of doing it. And I think supradiaphragmatic is probably the most important part to memorize. And remember that infraclav is kind of a differentiator between the three groups. So Ann Arbor keeps it separate, EORTC groups it with the axilla, German groups it with the supraclav. And then remember that Ann Arbor separates the mediastinum, the right hilum versus the left hilum. Those are all three separate regions, whereas EORTC and German study groups just lump together the mediastinum and the bilateral hyla. That's only one group. So that's probably the most important takeaway. And then the other thing I'll mention real quickly is that Waldeyer's ring as well as the spleen are considered extranodal for staging purposes. Moving on now, let's talk a little bit about the pathology of Hodgkin lymphoma. So the classic finding, and what is known as classic Hodgkin lymphoma, is the presence of the Reed-Sternberg cell. This is that binucleated cell that has that owl's-eye appearance, and it's pretty rare in tissue samples. It only constitutes around 1% to 2% of the total tumor volume, and so that's why we said whenever possible it's important to try for an excisional biopsy because these cells are few and far between. The classic markers that you should know for Hodgkin lymphoma are CD15 positive and CD30 positive, and PAX5 can be weak positive. There are 4 subtypes within classic Hodgkin lymphoma. Nodular sclerosing, which has a good prognosis and is probably the most commonly seen subtype. Mixed cellularity is the next most common subtype. And it's less favorable compared to nodular sclerosing. And then rarely we might see lymphocyte-rich or lymphocyte-depleted subtypes. Lymphocyte-rich is associated with the best overall prognosis of these subtypes, and lymphocyte-depleted is associated with the worst prognosis. So remember, nodular sclerosing is the most common, accounting for over 70% of cases, and has a pretty good prognosis. Mixed cellularity is the next most common, accounting for around 20% of cases, less favorable than nodular sclerosing. And then lymphocyte rich and lymphocyte depleted are both rare, and they are the best and worst, respectively. So lymphocyte rich is the best, it's good if you're rich, and lymphocyte depleted is the worst. And then historically, nodular lymphocyte predominant Hodgkin lymphoma was actually classified as a non-classic Hodgkin lymphoma, but it's actually now being reclassified as a nodular lymphocyte predominant B-cell lymphoma. And indeed, it does have very indolent behavior. It actually behaves like an indolent low-grade B-cell lymphoma, hence the reclassification. And the pathognomonic finding for the nodular lymphocyte predominant subtype is that popcorn cell. And it is actually CD15 negative and CD30 negative, but it is CD20 and CD45 positive, and PAX5 is usually a strong positive. So the nodular lymphocyte predominant B-cell lymphoma is treated like an indolent B-cell lymphoma, and the treatment paradigm is totally different than for classic Hodgkin lymphoma. I think once we start talking about staging and risk stratification, then some of the stuff about, the different lymph node regions and how they're classified is going to start to make more sense in terms of how this is actually applicable. Lymphomas are staged using something known as the Ann Arbor staging system. For most other cancers, we stage them using the TNM staging system. But for lymphomas, remember, it's just the Ann Arbor staging system. So stage 1 through 4. And it's fairly easy to remember. So stage 1 is just a single node or nodal group. Or you can have a single extranodal site without nodal involvement. So basically just one place is stage 1. Stage 2 disease is if you have 2 or more groups on the same side of the diaphragm, or if you have limited contiguous extranodal involvement. That makes it stage 2. So stage 1, think just one nodal conglomerate. Stage 2 is 2 or more groups, but on the same side of the diaphragm. If you have nodes on both sides of the diaphragm, then that makes it stage 3. Or if you have nodes above the diaphragm, for example, plus splenic involvement, then that makes it stage 3 as well. And then finally, stage 4 is if you have non-contiguous extranodal involvement. So if you have nodal involvement, but then you also have non-contiguous extranodal involvement. So in addition to the stage number, so 1, 2, 3, or 4, we will also often add modifiers to this staging system. So if you add a modifier of A, so stage 1A, for example, that means that the patient does not have any B symptoms. If you add 1B, then that means that they do have B symptoms. And remember, B symptoms are greater than 10% unexplained weight loss in 6 months, fever greater than 38 degrees Celsius, or drenching night sweats. And this does go into the patient's risk stratification because remember, presence of B symptoms is a negative prognostic factor. We can add a modifier E if they have extra lymphatic involvement. So for instance, if they had splenic involvement, then we would add an E as a modifier. And then finally, we'll often add an X if the patients have bulky disease, which has been defined differently by different study groups, but it's accepted as bulky disease if it's greater than or equal to 10 centimeters or if it takes up 1/3 or more of the thoracic diameter. So bulky disease has an X at the end. And so that is the Ann Arbor staging in a nutshell. I think this image helps us to visualize it nicely. So stage 1 disease is a single lymph node region or a single extralymphatic site. Stage 2 is if you have 2 or more lymph node regions, but they're on the same side of the diaphragm. And if there's contiguous, limited contiguous extranodal involvement, that can still be considered stage 2. If there are multiple lymph node regions that are occupying both sides of the diaphragm, then that is classified as stage 3. Or if you have supradiaphragmatic nodes and splenic involvement, that's stage 3. And then finally, stage 4 is really diffuse extralymphatic disease, so involving something like the liver, the bone marrow, the lung, or the skin. That would make it stage 4. So once we have staged the patients, the next step before we treat them is to actually risk stratify them. And you will see that the treatment paradigms differ based on the patient's risk stratification. So when we think about risk stratification, the first thing to keep in mind is what stage disease do they have? Do they have early stage, meaning do they have stage 1 or 2 disease where their disease is limited to one side of the diaphragm? Or do they have advanced stage disease, stage 3 to 4, where the disease is involving both sides of the diaphragm? And once we have figured that out, the treatment paradigms are different for early stage versus advanced stage. For early stage disease, there's actually a further subclassification of favorable versus unfavorable risk. So we kind of risk group the early stage patients into favorable versus unfavorable. And we'll talk about what factors we think about and how we risk stratify them. And also keep in mind that there's different consensus statements. So for example, the EORTC versus the German Hodgkin study group, they have different ways of kind of splitting up favorable versus unfavorable. So we're just remember for now that early stage is divided into favorable versus unfavorable, and that determines the treatment paradigm. And then advanced stage is advanced, so it kind of has its own treatment paradigm. For advanced stage, we can use something known as the International Prognostic Score, or the IPS, to prognosticate their outcome, but it doesn't really affect our management. Advanced stage are typically managed all the same, and then for early stage, management is different for favorable versus unfavorable. Let's start by tackling early stage disease and identifying the risk factors that help us to differentiate favorable versus unfavorable early stage Hodgkin lymphoma. So just like we went through the different study groups and showed how they classify the lymph node regions differently. Remember, there was Ann Arbor versus EORTC versus the German Hodgkin study group. The way that we risk stratify patients is also different across the different study groups. And this confused me for ages, but really it just has to do with how these different study groups risk stratified patients when they were enrolling them into their clinical trials. And as a result, we just have to kind of know that these differences exist. For me personally, it's easiest to just memorize one study group's way of doing it. And for me, that's the German Hodgkin study group. I just memorize how they kind of classify their nodal regions, how they risk stratify favorable versus unfavorable, and then for their trials, kind of keeping in mind how they treat their favorable versus unfavorable risk factor patients. If you have the capacity for boards to memorize all of them, that's fine. For me, it's easier to just kind of stick with one, but really it's whatever floats your boat. So across the different groups, 3 of the things that we're looking at are going to be identical. So the ESR, the size of the mediastinal mass, and the number of lymph nodes. Where, ESR, the size of the mediastinal mass, and the number of lymph nodes are the same across all of these different groups. So the things that are different is that German Hodgkin's cares about if there's extranodal extension. EORTC cares about if they're elderly patients, so greater. They define an age cutoff as greater than or equal to 50, and NCCN cares about bulk. So if it's greater than or equal to 10 centimeters, but they're all thinking about the ESR, the mediastinal mass ratio, and the number of nodal sites. The cutoff for the number of nodal sites for German Hodgkin's is 3. So if you have 1 to 2 nodal sites, that's considered favorable. But if you have 3 or more, it's considered unfavorable. For EORTC and NCCN, the cutoff is 4. So if you have 1 to 3 nodal sites, it's favorable. But if you have 4 or more, it's unfavorable. So German Hodgkin's is a little bit more conservative with regard to the number of nodal sites. All of the groups pretty much have the same exact mediastinal mass ratio. So if the mass that's occupying the mediastinum takes up greater than 1/3 of the maximum intrathoracic kind of width, then that is considered unfavorable. For EORTC, they define it slightly different. They use the mediastinal thoracic ratio, which is the maximum width of the mediastinal mass over the intrathoracic diameter, specifically at T5 to T6 level. But just remember mediastinal mass ratio greater than 1/3 across all of the groups. And then finally, the ESR of greater than 50 is considered unfavorable if there's no B symptoms. But if patients do have B symptoms, then an ESR of greater than 30 is considered unfavorable. And that applies for the German Hodgkin's and EORTC. NCCN says if you have any B symptoms, then you're considered unfavorable, or if you have an ESR of 50 or higher. And then those are kind of the things that are consistent across all the groups. So ESR and B symptoms, the mediastinal mass ratio, and the number of nodal sites. And remember, for German Hodgkin's study group, the cutoff is 3. For EORTC, the cutoff is 4. So for German, 3 or more makes you unfavorable. For EORTC, 4 or more makes you unfavorable. And same for NCCN. And then that final risk factor for German's Hodgkin's study group is extranodal extension, an extranodal lesion. For EORTC, it's the age cutoff of greater than or equal to 50 years old. And for NCCN, it's having bulky disease greater than or equal to 10. Keep in mind, sometimes with Hodgkin's, you'll hear 7.5 centimeters as a cutoff for bulk. And that just comes from retrospective data from Memorial Sloan Kettering, which uses 7.5 centimeters as a cutoff for bulky definition in areas other than the mediastinum. So sometimes you might hear that 7.5 centimeters, and that always confused me as well. But again, it just has to do with different studies and how they define things differently. So big takeaway, early stage disease is risk stratified into favorable versus unfavorable based on 4 risk factors, and those 4 risk factors differ between the different study groups. But remember that the treatment paradigms are different for early stage favorable versus unfavorable. Advanced stage disease has its own treatment paradigm. So this is stage 3 to 4 disease. And there's not really, for early stage, we classify as favorable versus unfavorable, and then our treatment actually differs based on that classification. For advanced stage disease, they're all treated the same, but there is something to be familiar with. It's called the International Prognostic Score, or the IPS, and it's basically just 7 factors that all go into a scoring system, and the more factors you have, the more unfavorable factors on this 7-point system that you have, the worse the expected progression-free survival and overall survival. So these are all bad prognostic factors, essentially. And the more that you have, the worse the prognosis. So there's a mnemonic for this IPS system. It's called SAW-meal. And SAW-meal stands for each of the 7 factors, and you get 1 point per factor. So what are those factors? So S is stage 4, A is age greater than or equal to 45, W is a white blood count of 15,000 or greater, M is male gender, E stands for erythrocytes, and it's really your hemoglobin of less than 10.5 is a bad prognostic factor. Albumin, so if you have low albumin or less than 4. And then finally, L is lymphocytes. So if lymphocytes are less than 600 or less than 8% of your white blood cells. So just remember, SAW-meal is the mnemonic, and each of those letters stand for one of the 7 factors. And as your score increases from 0 to 7, there is worse and worse predicted progression-free survival as well as overall survival. So worse prognosis. And so now that we understand how we stage Hodgkin disease and how we divide into early stage favorable versus early stage unfavorable and then advanced stage, we can now get into some of the treatment paradigms. The easy thing about Hodgkin lymphoma is that no matter which risk category you fall under, whether it is early stage favorable, early stage unfavorable, or advanced stage, the first step is always going to be the same. It's always going to be ABVD chemotherapy for 2 cycles. And after those 2 cycles of ABVD, the next step is to get a restaging PET scan. And it's really the result of that restaging PET scan that determines the next step. So if the result is good, so if it looks like the initial disease that was present on PET scan has responded, then you can imagine the subsequent therapy is going to be less aggressive than if the response on the PET scan is bad, meaning either the tumor did not respond or it progressed, right? And so the first step for all of the different risk categories, like I said, whether it's early stage favorable, early stage unfavorable, or advanced stage, it's easy to remember. It's going to be ABVD chemo times 2 cycles, followed by a restaging PET CT. And then on that restaging PET CT is where we're going to actually get some of the response assessment. And the way that we evaluate the response is using something called the Deauville score. And the Deauville score it's really just named, I believe, after the city in France where somebody came up with it. But the Deauville score is a score that goes from 1 to 5, and it basically characterizes the degree of uptake relative to various things. So a Deauville score of 1 to 3 is typically considered a good response, and a Deauville score of 4 to 5 is typically considered a bad response. So what do all of these mean? For me, it's easy to just remember one number and what it means, and everything else I can remember kind of relative to that. So if you think about a PET scan and what it normally looks like, there is some normal background uptake, right? So in the mediastinum, there is some background uptake from the mediastinal blood pool. The liver also pretty avidly takes up the dye, and the liver is usually more than the mediastinum. So Deauville 3 is what I always remember first, and I know that I can figure out 2 and 1 and 4 and 5 based on knowing what Deauville 3 is. So 3 is right in the middle, and the uptake of the lesion is greater than the mediastinum, but it's less than the liver. So Deauville 3 is greater than the mediastinum, but less than the liver. It's 3, so it's right in the middle. Deauville 4 then is if uptake is greater than that of the liver, and 5 is if the uptake is markedly greater than the liver or there are new lesions present. So 4 is more than the liver, 5 is markedly more than the liver, or new lesions are present. And then 2 and 1 are kind of on the other side of that spectrum. So 3, remember, was greater than the mediastinum, but less than or equal to the liver. 2 is less than or equal to the mediastinum. And 1 is no uptake, so similar to background. So ABVD times 2 followed by a restaging PET CT for pretty much all patients. And then based on the Deauville score, when you go to evaluate the response, the rest of the therapies will kind of be determined. And remember the number 3. 3 is greater than the mediastinum, but less than or equal to the liver. And if you remember 3, then you can work either forwards or backwards for the rest of the scores between 1 and 5. And I know I kind of probably oversimplified it by saying a Deauville of 1 to 3 is good and 4 to 5 is considered bad. The reason I said that is because most trials consider Deauville 1 to 3 as a complete response, and Deauville 4 is a partial response, and then 5 is really just refractory disease because it either did not respond or it progressed through chemo. But keep in mind that some trials will consider Deauville 3 as a partial response as well. So like everything, when it comes to these trials, nothing is completely black and white. I think generally it is accepted that Deauville 1 to 3 is a complete response, Deauville 4 is a partial response, and then Deauville 5 is refractory disease. So that's why I said Deauville 1 to 3 is good, 4 to 5 is bad. But 4, keep in mind, is bad in the sense that it's not a complete response, but it is at least a partial response. So now that we understand the Deauville score, we can really talk about kind of a summary of management. And there's a lot on this slide here, and there are a lot of different treatment options depending on the Deauville response. I think a lot of this will make more sense after our next talk, where we actually kind of one by one go through the different studies and address these different treatment paradigms. For now, just remember that for Hodgkin's disease, no matter what stage and risk stratification, so whether you're early stage favorable, unfavorable, or advanced stage, it's safe to say that the first step is going to be ABVD times 2 cycles, followed by a restaging PET CT. And then if you have a Deauville 1 to 3 response, so remember that's a complete response, it's going to be a slightly less aggressive option versus if you have a Deauville 4 to 5. If you have a Deauville 4 to 5, then it's either going to be more cycles of ABVD, or in the case of early stage unfavorable or advanced stage disease, you can consider escalated therapy with a more aggressive chemotherapy regimen called Bayacop. This is a chemo regimen that's quite toxic, and I think it's used more commonly in Europe than it is in the United States. So more aggressive chemotherapy and or radiation typically. I really do think that these treatment paradigms are going to make a lot more sense when they are presented in the context of the clinical trials that kind of establish these paradigms. And so I'm not going to, read through the different treatment options for each of these right now. I think it's important to understand that the first step for all of Hodgkin lymphoma is typically ABVD times 2 followed by a restaging with PET scan. For early stage disease, there are trials that have employed radiation as an option, and there are also trials that have not employed radiation as an option. When we get into that data, what you'll find is that the data does actually support a progression-free survival benefit with radiation. However, despite that progression-free survival benefit, many may choose to omit radiation just because there is still very good overall survival with the regimens that do not employ radiation. And there's also good salvage with autologous stem cell transplants. And so the idea is that this allows you to avoid the long-term toxicity of radiation. It's important to realize, though, that the radiotherapy regimens, and we're going to talk in a second about what ABVD actually is and what the toxicities of these agents are, that can also cause significant long-term toxicity, right? The A in ABVD stands for adriamycin, which is also known as doxorubicin. It causes significant long-term cardiotoxicity. And so it's always a trade-off. It's always a risk-benefit discussion, and it's always a multidisciplinary discussion with the medical oncologist and the radiation oncologist to kind of decide which therapy is thought to have the least long-term toxicity for these patients. So understand that, for all of these different stages, especially in early stage disease, there are options for just chemotherapy alone. There are also options that utilize radiation, and it's always going to be a risk-benefit discussion. And, over time, as the chemotherapy regimens have gotten better, radiation has actually been used less for this disease site. For advanced stage lymphoma, it's, most patients will actually respond fairly well to just ABVD for 6 cycles. And so for advanced stage lymphoma, we employ radiation even less frequently. Oftentimes, we're just utilizing it if patients have really bulky disease or if they have skeletal involvement or if they have residual PET positive disease or something like that. So for advanced stage, it has, it's used even less often. So I'm not going to go through each treatment paradigm right now. It's definitely going to make more sense in the context of the evidence. What we will do now, though, is kind of talk about the overarching principles of chemotherapy as well as radiation, and talk about involved site radiation, what that is, and how that's different from what was historically done. Before we get into that, though, I just want to take a moment to mention the nodular lymphocyte predominant Hodgkin lymphoma. Remember, the one that's now being reclassified as nodular lymphocyte predominant B-cell lymphoma. This is not treated the way Hodgkin lymphoma is. It's a completely different entity, and it is treated very similarly to a low-grade indolent B-cell lymphoma. So we don't actually use chemotherapy for this up front. We typically just consider involved site radiotherapy alone to 30 to 36 gray for stage 1A or 2A favorable nodular lymphocyte predominant disease. So typically the dose is 30 gray, but if the tumor is greater than 5 centimeters, we consider boosting it to 36 gray. And so it's usually typically just treated with involved site radiotherapy. If there are unfavorable risk factors, we can consider rituximab-based chemotherapy as we would for non-Hodgkin's lymphomas, because remember that the NLPHL is CD20 positive. And so just like those other indolent B-cell lymphomas that are CD20 positive, if there are certain unfavorable factors, we can consider rituximab-based chemotherapy. But this is a completely different treatment paradigm compared to Hodgkin. I want to end the talk then by really just talking about some of the overarching treatment paradigms for Hodgkin lymphoma, and maybe not focusing so much on the memorization of what are the specific regimens at this point. We will do that in our next lecture when we get into the evidence, but just kind of understanding some of the general treatment concepts, starting with the chemotherapy regimens. So you've heard me say ABVD a lot. What is ABVD? What does that stand for? So ABVD stands for adriamycin, which is also called doxorubicin, bleomycin, vinblastine, and dacarbazine. Those are the agents in ABVD. ABVD is given in monthly cycles. So each cycle is 1 month, so it's given every 28 days. And each cycle requires 2 infusions per cycle. So there's an infusion on day 1 and there's an infusion on day 15. In the short term, the acute toxicities are really things like nausea, vomiting, hair loss, bone marrow suppression, so typical things that you would expect from chemotherapy. The late toxicities mainly are cardiac toxicity and pulmonary toxicity. So adriamycin is the agent that is responsible for permanent cardiotoxicity, and bleomycin is the agent that's responsible for pulmonary toxicity. So remember back when we talked about the workup, we said that these patients should be getting an echocardiogram or a Muga scan for their cardiac function, as well as PFTs and a DLCO. That is because we know that they're going to need ABVD, which causes long-term cardiac and pulmonary toxicity. So we need to establish a baseline. Some of the studies that we'll talk about in the next lecture actually de-intensify the chemotherapy if patients have a good response up front to ABVD 2 cycles. And the subsequent cycles, they actually consider de-intensifying with just AVD. So they drop the bleomycin and just use AVD to try and decrease some of that pulmonary toxicity. So ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine, that's a really good, you should know what that regimen is and what drugs are in it. I will give a little mnemonic that one of my old senior residents taught me, which is that there's ABVD is the most common chemo regimen for Hodgkin, and then R-CHOP is the one that's very common for non-Hodgkin lymphoma, like diffuse large B-cell lymphoma, for example. So in R-CHOP, the O stands for Oncovin, which is the brand name for vincristine, and it's confusing because R-CHOP has vincristine and ABVD has vinblastine, and how do you remember which is vinblastine and which is vincristine? ABVD has a B in it, and so it has the vinblastine, which also has a B in it. And then the other one, which is R-CHOP, has the Oncovin, which is also vincristine. So if you can't remember which one has vincristine, which one has vinblastine, remember that ABVD has a B in it, and so vinblastine also has a B in it, and so vinblastine belongs with ABVD. So ABVD is adriamycin, bleomycin, vinblastine, and dacarbazine. We also briefly mentioned another alternate chemo regimen, which was called BEACOP. BEACOP has been utilized for early stage unfavorable as well as advanced stage Hodgkin lymphoma as an intensified treatment that has been used in the setting of a poor response for these higher risk patients. However, it is a very, very, very toxic regimen, has a much higher incidence of bone marrow suppression as well as alopecia, and I have actually not seen it used because it's not commonly used in the United States. It's used more often in Europe, I believe, but it's folks in the United States that I've talked to just really don't like it. They really do not use it. But BEACOP has bleomycin as well as etoposide, adriamycin, cyclophosphamide, vincristine, procarbazine, and prednisone. So it has more drugs, and as a result, it's more toxic. And so I have not seen it used very often, but it has been studied in the setting of intensified treatment for patients that have a poor response if they have either unfavorable early stage or advanced stage disease. And then an older study used the Stanford 5 regimen, which has nitrogen, mustard, doxorubicin, vinblastine, vincristine, bleomycin, etoposide, and prednisone. And this is a a quicker treatment because it takes only 8 to 12 weeks to deliver 4 to 6 cycles versus ABVD, which took 16 to 24 cycles. And it does include lower cumulative doses of doxorubicin and bleomycin, but the Stanford 5 regimen has only been studied in studies that utilized radiotherapy. And so radiotherapy really should not be omitted if the Stanford 5 regimen is used. Again, I have not seen this used, not like I've seen a ton of lymphoma, of Hodgkin lymphoma, but I have not seen the Stanford 5 regimen used as well. And then an even older trial that I don't even have on this slide is something called MOP, which is a historic regimen you might hear of. It has mustard, vincristine, procarbazine, and prednisone. It has high rates of sterility as well as secondary acute non-lymphocytic leukemia. And so it's really not used very often at all. So I think the most commonly used chemotherapy regimen in the US for sure is just ABVD. So definitely remember that. Remember the cardiac and pulmonary toxicity is late effects of ABVD. And then keep in mind that ABVD can be de-escalated if patients have a good response up front and kind of de-intensify to take out the bleomycin and just do AVD. Some additional agents that you might see used in the setting of advanced, relapsed, or refractory disease that I think are worth mentioning include brentuximab vedotin as well as nivolumab. So brentuximab vedotin, or you might see BV-AVD, and the BV stands for brentuximab vedotin. This is a CD30 antibody. So remember, Hodgkin lymphoma has Reed-Sternberg cells, which are CD15 positive and CD30 positive. So brentuximab actually targets that CD30. And this is used in the setting of advanced as well as relapsed disease. And it's very expensive. And as a toxicity, it can actually cause severe neuropathy. And so that's definitely something to keep in mind. Big risk of neuropathy with brentuximab vedotin, which is that CD30 antibody. The other immunotherapy agent, nivolumab, which is a PD-1 inhibitor, can be used in relapsed refractory disease as well. One thing to keep in mind is that if disease relapses over 1 year after patients have had a complete response, then it's okay to consider repeating first-line systemic therapy. But if they have a relapse within less than 12 months, or if they're not responding to upfront chemotherapy, then that tells you need to change the agent. And so if they don't have an upfront response to ABVD or something like that, that's when, brentuximab vedotin or a PD-1 inhibitor would be employed. And then from a radiotherapy perspective, I think, I did use the term involved site radiotherapy or ISRT. I think I briefly mentioned that a little bit ago. And I think it's important to kind of talk about what ISRT is and where it comes from and why we do it. So involved site radiotherapy, whenever you're describing what type of radiation patients with lymphoma should get, the correct answer is typically ISRT or involved site radiotherapy, at least for now. And the field of lymphoma has actually come a long way. I should say the field of radiation when it comes to treating lymphoma has come a long way. So in the 1970s and earlier, so really in the 2D era, we used to do what was called total nodal irradiation. So there was a mantle field and then an inverted Y field. And so the mantle field was really the top, so treating the neck and the axilla and the mediastinum. And then the inverted Y field was treating the para-aortic and the pelvic nodes. So total nodal irradiation is what used to be done. We then moved to subtotal nodal irradiation. And then we moved to involved field radiation therapy in the 3D era, kind of in the 90s and the early 2000s. And involved field radiation therapy involved, so if you had a cervical node, for example, you would just treat the entire cervical chain. And then in the modern era, where we actually can utilize PET-CT fusion and, we have a better sense of where the disease was to begin with, and we have better imaging, such as the PET-CT for staging, and we have more sophisticated radiation techniques. we have moved to either involved node or involved site radiotherapy. It always confused me what was the difference between involved node or involved site radiotherapy. So involved site radiation is typically what's used in the United States. Involved nodal radiation therapy requires having your pre-chemotherapy PET CT in the same position that you would be in for your radiation treatment. And realistically, in the US, our pre-chemo PET CT is ordered by either a medical oncologist or someone that's not a radiation oncologist, and it's just a diagnostic PET CT scan. It's not acquired in the simulation position. And so for that reason, we utilize involved site radiotherapy, and this is typically what we do in the US. Involved nodal radiotherapy, my understanding is that it's often done in Europe, where the same oncologist that's going to be administering the chemo is the one that's going to be planning the radiation. That in Europe, it's possible to get involved nodal radiation because that pre-chemo PET might be ordered by someone who knows how to deliver the radiation. But in the United States, it's really involved site radiotherapy that we use. And so the definition of involved site radiation is really just treating the area where the nodes were positive, and it's less involved than involved field radiation, for example, where if there was a cervical node, then you would just treat the entire cervical chain. There are nice guidelines from ILROG, which is the International Lymphoma Radiation Oncology Group, that kind of defines the principles of involved site radiotherapy. And essentially, when we're doing involved site radiation, what we're trying to do is treat where the disease used to be, but accounting for the anatomical changes that have happened since the disease has shrunk from our induction chemotherapy. So with ISRT, we create a post-chemotherapy clinical target volume that our hope is that this will encompass our pre-chemotherapy tumor volume, or GTV, cropped out of any structures that were uninvolved or any barriers to spread, just given anatomic changes from tumor shrinkage. So for example, if you had a huge mediastinal lymphoma, for example, and you received upfront ABVD and the lymphoma shrank, if you just fused your pre-chemo PET scan and drew that tumor, there would be a significant portion of it going into the lung. But there's really a membrane there, right? The pleura are there. And so you're not going to have actual tumor inside of the lung. And so our post-chemo CTV can be cropped out of that, and we can kind of account for the anatomical changes that have taken place since the tumor shrunk from that upfront chemotherapy. Typically, the way that we think about this is that our craniocaudal expansion should really include the pre-chemo volume in the superiorly and inferiorly, so in that craniocaudal plane, plus an additional margin for uncertainty. And then axially, so kind of in the horizontal plane, that's really where the boundaries of the lymph node compartment come into play. So if you think about the neck or the axilla or the groin or something like that, usually we're more worried about craniocaudal spread than axial spread. And so our margins tend to be bigger, and they tend to be more generous in the craniocaudal plane. In terms of dosing, these are just some relative guidelines, but typically we think about 20 to 30 gray for early stage favorable disease, 30 to 36 gray for early stage unfavorable disease. So typically 30 gray, but we can consider a 6 gray boost if there's bulky disease. Same thing for advanced disease, 30 to 36 gray, considering that 6 gray boost if we're trying to consolidate bulky disease or something like that. And then if there is a partial response or if there is refractory disease, we might consider increasing that dose from, in somewhere in the range of 36 to 45 gray. So 20, 30, 30 to 36, and 36 to 45, 45 in the case of, partial response or refractory disease, again, taking into account what therapy they've had, how bulky it was, other risk factors and things like that. Those are kind of that's the realm of the doses that we're really talking about. And then when it comes to palliative treatment, if that's what we're thinking about, there's many options ranging from anywhere from 4 to 30 gray. I sort of alluded to this earlier, but in the age of modern chemotherapy, there have been several trials that have come out that kind of omitted radiotherapy and showed no significant difference in overall survival. And there has been a move away from utilizing radiation for lymphoma because there is this idea that radiation confers increased toxicity. And so there is a rationale for omitting radiation. Equivalent overall survival without radiation. We can achieve favorable salvage rates with autologous stem cell transplant. And we are concerned about long-term toxicities of radiation. And remember, these patients have pretty excellent prognosis. And so we really do care about what their long-term toxicity profile looks like because it's going to affect their quality of life. It's important to realize, though, that in those studies, chemotherapy alone was not non-inferior to chemoradiotherapy in terms of progression-free survival. So radiation, and we'll talk about this in our next lecture, but radiation does confer a progression-free survival benefit based on the data that we have. But that said, there is still a reasonable rationale for the omission of radiation, given that equivalent overall survival and the salvage rates and things like that. So it's always going to be a risk-benefit discussion, but as radiation oncologists, it definitely behooves us to understand that chemotherapy also confers cardiotoxicity. Each additional cycle of ABVD confers around an equivalent of 4 gray mean dose to the heart. And so at some point, and again, you have to think about where the tumor is, how big it is, what the radiation field is going to look like, and things like that. But at some point, after enough cycles of chemotherapy, you might consider adding radiation and actually omitting additional cycles of chemotherapy. So it's always important to have multidisciplinary discussion, keep in mind, considerations of what the plan is going to look like and what the dose distribution will be and things like that. So I just want to end this overview talk with a quick summary slide on everything we've talked about so far. So remember, Hodgkin lymphoma has an excellent overall prognosis, and that's why we think so much about what long-term toxicity is going to look like for our patients. Classic Hodgkin disease is characterized by the Reed-Sternberg cell. It is CD15 positive, CD30 positive, and there are 4 subtypes, but nodular sclerosing is the most common, and it has a pretty good prognosis. Non-classic Hodgkin historically was thought of as nodular lymphocyte predominant Hodgkin disease, but it's actually being reclassified as a B-cell lymphoma. It's characterized by having a popcorn cell, which is CD20 positive and CD45 positive, but it's CD15 and 30 negative. It behaves similarly and it's treated similarly to an early stage, low-grade non-Hodgkin lymphoma. So oftentimes those are treated with just radiation alone at 30 to 36 gray. For Hodgkin lymphoma, we stage it using the Ann Arbor staging system, and then we risk stratify it as well. So early stage is divided into favorable versus unfavorable disease, and then the treatment paradigms are different for favorable versus unfavorable. Things that we think about for making you unfavorable is typically based on the mediastinal mass ratio, the number of extranodal sites, the ESR and the B symptoms, and then remember, criteria for favorable versus unfavorable vary depending on the study group. So German Hodgkin versus EORTC versus NCCN. So it's important to recognize which study group risk stratification system you're using, and then based on that also which treatment paradigm you're using. And then remember, for advanced stage, we can prognosticate based on the IPS scoring system. Remember those SAW, meal, those 7 risk factors. But that's really just a prognosticator. It doesn't really affect our management. And when it comes to the treatment paradigm, the standard is ABVD times 2, followed by a PET response. And then treatment options include subsequent radiotherapy or chemotherapy alone, depending on the initial stage and risk stratification, as well as their PET response after 2 cycles of ABVD. In terms of doses, think about 20 to 30 gray for early stage, favorable, 30 to 36 gray in all other cases, and then going up to 36 to 45 gray if patients have residual or refractory disease. And when we talk about studies, we will talk further about how radiation improves the progression-free survival. But remember, we mentioned that there is a rationale to omit radiation, especially in young patients, just because of equivalent overall survival with chemotherapy alone, as well as favorable salvage options for these patients. And so that ends our overview. I will see you in the next talk where we dig into the evidence. Thank you for your attention.